Ladies and gentlemen, I am Dr. Laxman, a consultant surgeon practicing in Bangalore. My areas of interest in practice include gastroenterology, that is surgical gastroenterology, and laparoscopic surgery. Over the last 2 decades, the practice of medicine had a paradigm shift when the concept of evidence-based medicine was introduced. Medicine as a science, if it has to succeed, has to be based on evidence. What we're going to learn over the next 45 minutes or so would be to understand the basic concepts of what evidence-based medicine involves. It by no means prepares you to have a full and extensive knowledge of the practice of evidence-based medicine, but what we hope it will do is help you to understand the basic concepts and stimulate you to learn more about this concept called evidence-based medicine. Sackett defines evidence-based medicine as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Each one of these qualities that he describes is very important. Every time we make a clinical decision, we consciously think of what the evidence is. Explicit essentially involves the use of very clear-cut questions which answer very clearly what our clinical decisions have to be. And the word judicious is particularly important because the evidence that we seek may or may not be available. It may or may not be appropriate in a given clinical situation. And so, finally, it is the responsibility of the treating doctor to use his judgment in interpreting the evidence. And the latter part of the definition, as you can see, clearly says that you have to use your practice, your judgment, and your surroundings before you apply the knowledge that is gained from evidence. If you look at the way the thought of evidence-based medicine came about, we must go back to the history of medicine. Earlier, religion and medicine were one and the same. Most of medicine was delivered by religious leaders. Even to this day, certain parts of African countries practice what is called the voodoo medicine, which in fact essentially is practiced by the religious leaders of that area. But then, through the period of Renaissance, the concept of rational thought, logic, and deriving conclusions came about, and that led in several fields to what we now call scientific temper. Also, it is of note that earlier, surgical specialties, for example, were never thought to be very scientific and were relegated to the barbers of the day. And even to this day, surgeons, for example, in the United Kingdom, are called misters rather than doctors. But we have come a long way from these days. We now talk about the scientific temper or the science of medicine as exemplified by evidence-based practice. And by looking at what we call science, we also are now in a position to look at and analyze what we see in the so-called parallel medicine. Various disciplines like Ayurveda, homeopathy, or Unani, or whatever else, or magnetotherapy, if you want to consider that, they all claim to have quite a few good results from the kinds of ministrations that they do. In fact, the name Sushruta stands out very well in surgical specialties. But if you look at it in a strictly scientific way, what is propagated, or what is recommended for use, is mostly coming from anecdotal experience. Documentation is limited, and these kinds of situations where anecdotal experiences are given prominence and where documentation over a large number of people is not available is considered more traditional than progressive. Now, if you transpolate that into the present day practice, particularly among surgeons, that's why the graphic here shows a surgeon, it will be quite humbling to see what many of us do. Many of the things that we do is because we have always done this. Or it says it works very well in our hands. Or more so, it says we've had no problems with it. Finally, you say, I'm an expert in the field, I say so. Now, in the eyes of evidence-based medical practice, none of these situations and none of these contentions will stand the test of time or are considered appropriate. For you to have evidence-based practice, you have to be scientific. And it is again quite a revelation to see that Ruskin in 1853 defined science as follows. The work of science is to substitute facts for appearances and demonstrations for impressions. What it essentially means is that what appears to be a phenomenon may not necessarily be so. It has to be clearly replaced or shown to be factually correct, and that you have to have demonstration of a given fact, preferably and in fact essentially at more than one place to say that something is scientifically valid. Hence, the endeavor of evidence-based medicine is to go away from the anecdotal experience level, consciously create or discover the scientific basis for what we do, and as this definition says, demonstrate that what you are saying is indeed correct. And this demonstration, as I said and as I repeat, has to be across several areas and several studies. And you will find that in the coming slides, every single attempt is to show in a very clear and a non-controversial manner that what we are saying about a given disease, be it its etiology, be it its treatment, be it its prognosis, is all completely based on scientific observations. Now, it becomes more important in a field like medicine because everything is somewhat gray in its existence. There is no black and white in medicine, and so there will be areas which are controversial, and these become very important, particularly once you graduate and either take up postgraduate studies or continue your continuing medical education in whatever specialty you're in, including family practice. What it essentially means is that at the undergraduate level, the teaching has been to give you very specific ideas, and these are didactic and not necessarily stimulatory, because at that level, you're basically expected to know certain standard procedures. Whereas when you grow in your specialty or in your field of practice, then you find that there are many controversial topics, and everything is, or most of the things are a little gray, and this is when your skills in understanding and analyzing evidence becomes very important. Because several of these papers and concepts that you come across, that you read or hear or practice, will have controversies. And then to make a decision in an individual case, you as a practitioner will be called upon to analyze facts. You must also evaluate other views and see why your view is, if at all, better than the other view. And in fact, if you cannot have consensus, accept differences, and at a given time, do what you think is best for the patient. Of course, backed by evidence of your own. Now, to be able to do this, you really need to understand concepts behind evidence-based practice of medicine, and the subsequent slides are going to prepare you, hopefully, for that. The very first thing that you look for in evidence is to know two things about a particular piece of information that you gather, be it from a talk or be it from a paper or an article that you study. The two questions are, how recent is the study and how much is it scientifically valid? What is important to know is that what we practice must be of recent origin. The concepts must be of a recent origin. And if you look at the information that we have, the most recent information that you get would be from a conference paper presentation. The moment some scientific study is done, an abstract is given to a scientific conference, the paper, if it is accepted, will be read at that conference, and the time lag between the end of research and analysis of data and the time you read your paper is perhaps about 6 months. Now, if you then go to a peer-reviewed journal article, I'll tell you what a peer review is a little later, then you'll find that the time taken from the time you submit the paper to the time it sees the light of the day in the form of a printed journal would probably be about 6 to 9 months. Reviews in journals put together ideas of many journal articles and give you a consolidated view, and that would again take about 6 to 9 months to publish. But if you have reviews in compendia, for example, I can tell you in a surgical specialty you would have something like Surgical Clinics of North America or Recent Advances in Surgery or something like that. When you have such compendia giving you information, the information would actually be from studies that are done more than a year ago. Similarly, if you go for a textbook, many times because of the age of the textbook and because of the way it is published, the information that you have would be sometimes as old as 5 years old. And so, when you're getting your continuing medical education done, while textbooks are the basis from which we learn all of medicine, it is important that you read journals in the field of your specialty, read review articles, and attend conferences to be really abreast of what the scientific advances in your field are. Types of studies are something that we need to know about. Most of the studies fall into two major groups called descriptive studies and evaluative studies. Now, if you have case reports, for example, or a series of cases that you see, or large series in epidemiology, for example, where you have what are called cohort studies, these are descriptive studies. In a sense, it looks at the way a disease has its manifestation across a population. It is not designed to evaluate a particular intervention, an operation, or a medication or whatever. When you have evaluative studies, these are what are called controlled studies that are normally encouraged, and this would have some kind of intervention, and the intervention is then evaluated for its outcome, good or bad or indifferent. These are the two main types of studies that you think of, and when you're looking at the kind of literature that you see, it may be either primary literature or secondary literature. Knowing about the literature is important because you will have to read articles and analyze them to know whether you have the kind of evidence that you need to have the kind of practice that you actually carry out. If you are looking at treatment efficiency, for example, a particular medication in the treatment of hypertension, you need to have a randomized controlled trial comparing that against or versus a gold standard, and then decide whether that particular medication is indeed important or significant or not. Similarly, for a diagnostic accuracy, the value of a given test, MRI in abdominal mass, for example, you need to have a controlled trial of an MRI in a given population as compared to perhaps CT or an ultrasound, and then decide which one of them is the best. In a prognosis of a condition where a large population is involved, you're looking at what we call cohort studies, where across the board you may study 500, 1,000, 1,500 cases of tuberculosis in a given population, for example, and then see how they behave and what the outcome is over a period of time. Similarly, for etiology of the disease, you go for cohort studies. For preventive measures, particularly useful in immunization methods, you go for RCTs, that is randomized controlled trials, or cohort studies. And quality improvement is another area that we keep looking at. Even there, RCTs are important. Now, the idea of giving this list is not to confuse you, but to tell you that these kinds of questions that we have clinically, whether it is about treatment, diagnosis, or prognosis, the best information that you get and the dependable information that you get will be based on studies, as I have shown, which may involve either a controlled trial or a cohort study. So you need to first understand what these are, and I'll say a few things about it as we go along. This is about primary literature, but in a secondary literature, which I think is very useful for practicing doctors, we look at the results of several primary articles. What is done in a secondary literature is that people who are specialists in the field will look at the data coming out of several individual papers, several individual original articles, and then put them together. And they may be in the form of systematic reviews, they may be what are called meta-analysis, they may be decision analysis, and it may also be practice guidelines, usually put out by several organizations which are specialist organizations like the Cardiology Society or the Surgical Society or the Anesthesiology Society. And also there will be what are called consensus development conferences, where the given evidence that is available is analyzed by experts and they put out reports. And for the average practitioner like you and me, the best thing is to look at these practice guidelines or systematic reviews, where the hard work of collating data from original articles is done by somebody else, who in fact will be a specialist in the field, and he or she will give you a distilled and a summarized version of the evidence that is available. So I would strongly recommend that when all of us who are practicing doctors look for evidence, we must be looking for consensus reports, practice guidelines, and systematic reviews. The 4 S's of evolution, as propounded by Haynes, is something that we need to do and understand. The original studies are all the primary studies. Whatever is above that, the other 3 S's are secondary literature. And this is where you have synthesis, where, as I said, a lot of this information is collated, and you can even have synopsis, where the evidence value, again I'll be talking about it a little later, the evidence value of these synopsis or articles is again given to you. And finally, you will have a level where you have a computerized decision support systems. We have no access to this at the moment, but when EMRs become very popular, you will then have a role for CDSS. As for now, in our daily practice, we can be happy with synthesis and synopsis in learning about evidence for what we do. Now, this is an important concept that we need to understand, the value of studies as they occur. As I said, the value of an anecdotal experience is really, really minimal. I, as a surgeon, if I say tomorrow that you have to do this particular operation because I say so, because I'm an expert, that statement has very little value in evidence-based practice. I have to back my recommendation or my statement with actual data. The data can be collected and presented in various ways. The next best, which is nearly at the bottom end of the pyramid or the level of evidence, is retrospective studies. In retrospective studies, what you do is analyze the data coming out of a series of cases that you have perhaps operated on. Let me give you an example. I do a hernia. I do not have any prospective or any protocol for this, but I look at all the hernias that I have done over the last 5 years. Now, if I analyze it and tell you that this is what happened in terms of recurrence rate, in terms of the usefulness of a mesh or whatever, now, of course, its value is a little more than an anecdotal experience where I tell you my experience from 1 or 2 cases, because I perhaps, as an example, have 500 cases. But still, the value is limited because I have not really done it in a uniform manner. In any outcome, there are what are called confounding factors. This is a word that we have to understand. Confounding factors are factors which in fact have an influence on the outcome other than the intervention. For example, if you're looking at infection rates in a hernia repair, Now, it's not just the mesh or the sterility of the instrument that are involved. It also depends on the nutritional status of the patient, the age of the patient, presence or absence of immunosuppressive factors. So when you are actually evaluating the infection rates in a hernia repair, as an example I'm giving you this, retrospective studies don't really count because you have not actually controlled or taken into effect all these so-called confounding factors. Whereas in a prospective study, that is the next level of evidence, what we do is control for these factors. We have a standard protocol. The protocol says that the patient should not be immunocompromised, for example. He should not have medications like steroids or immunosuppressants. When you do that, then that factor, as a factor responsible for infection, is taken away. Similarly, for any of the given treatment outcome, you look at all confounding factors and take them away, have a regular protocol, and then you do the study. You have control on confounding factors, and the result that comes from that factor is important or significant. It becomes even more valuable when you randomize the studies. Now, you can have what is called a selection bias. It's not my intention to go into the details of this process, but you can have what is called a selection bias when you choose your patients. So when you do not choose your patients, but only control for confounding factors, then you have randomized the cases. Then the value of that study will be a lot more. Then you not only have you controlled factors, you have randomized them, and then you blind for the studies. There is an observation bias, just like a selection bias. There's an observation bias. In putting it in simple terms, I can say, if I as a surgeon am evaluating my own patients, I would be biased. I wouldn't like to see a failure in my own cases. I may see infection, there may be infection, then I may refuse to see it because I'm biased. So the evaluation for infection, for example, on my patients must be by another person who is not a person who has a potential bias. This kind of blinding, as we call it, the evaluation is done by an observer who doesn't know who has done the operation or what has been done. So once you blind the person, his aim is only to see whether there is infection or not. And so there will be no bias. So if you actually control for confounding factors by having a prospective control study, if you randomize it and then blind the person who is evaluating the outcome, you will have the best results or the most scientifically valid results from that particular study. And the problem with this kind of randomized, controlled, blinded studies are that it is difficult to have large numbers. In a given institution, you may not be able to generate the numbers that you need to extrapolate the results for a general population. Hence, the need for meta-analysis and systematic reviews. Examples of these reviews are the Cochrane collection and the reviews from McMaster University, the two leaders in evidence-based practice. What they do is put together data from similar randomized controlled trials and then collate and analyze the data from all these different studies and then give you the information or the result from a large number of patients. The larger the number of patients, more dependable is the result and more logical it is to extrapolate that result to the general population. Contrasted to this, if you have a very small number of patients, as seen from, say, an RCT from a single institution, then the value of that particular study would be limited. Now, after understanding the value of studies, we must, as practitioners, know a little bit about statistics. I find that for most of us, statistics is a very dry subject. We see it as a requirement to study in our P&S classes in the undergraduate period, and once you come out of it, you hardly ever think about it. But in fact, if you need to be an evidence-based practitioner, which we all of us should be, then you will find that some elemental or basic concepts of statistics is something which we should have. And while it is not the intention of this lecture to tell you about statistics, I would like to urge all of you to go into statistics and read up about it. But for the purpose of this particular presentation, what we need to understand is to know whether adequate numbers of patients were studied. As I said, if it's a very small study, the value would be limited. Was there a proper statistical test applied at all? Different kinds of groups of studies and different kinds of interventions need different kinds of statistical tests to be applied. So you must understand whether the proper test was applied, understand the meaning of p-value and confidence intervals. As I said, the purpose of this slide is to stimulate you to go back and read about these things rather than explain to you what statistics is. The other concept that we really have to understand is to know what peer review is. And this is a very important point in these days of web-based learning. All information on the web is not necessarily of scientific value. Why do I say this? The web is a free-for-all phenomenon. Anybody can write what they want, put what they want on the web, and there is no control on whether it really is the truth or not. The scientific community understands this completely, and the way it has addressed this problematic issue is to institute what is called peer review. I'll give you an example about what a peer review is. If I today as a surgeon publish or apply to publish a paper on hernia, for example, to a surgical journal, that journal will then put it on to 5 other surgeons like me, a specialist in the same field. They are in the know of what is going on, and they evaluate my study and see if it is scientifically valid. If the majority of them say that this particular study is a good study and that it has all the parameters that it has to have to be scientifically valid, only then the paper or the journal will publish that paper. Whereas if these people who are experts in the field, they're called the peers, if they tell the journal editor that there is something lacking in this, that is put back to the original author. It is sent back to me, for example, and it is my responsibility to suitably modify my article to make sure that the questions raised by the peer reviewers are addressed properly. Once this process, this to and fro process occurs 2 or 3 times, and once this process is completed, once the peers are convinced that it is an article with scientific value, only then it is published in the journal. So it is the responsibility of all practicing doctors to make sure that the journals that they read or the articles that they see on the web are all peer reviewed before they actually accept the concepts put forward in those articles. And as I said, in these days of web-based learning, peer review is something that we all have to be aware of, and we have to make sure that we only visit those sites and absorb information and accept information from those sites which are peer reviewed. I'm switching gears a little bit and digressing a little bit, as it were, to give you some idea about what is called the phases of a clinical trial. This is applicable to medication, not to operations, as it were. If a new drug has to come into the market, it has to go through several stages of development. And I'm going to spend 5 minutes on this so that we all understand what these phases are, because what we apply must be from a proper phase of the trial, information from a proper phase of the trial. First of all, when a drug is being developed in a so-called preclinical or PC stage, it is used in laboratory and used in animals, and it only looks at the safety and activity. Now, in so-called phase 1 trial, the medicine is used on healthy volunteers, and it is designed to look at safety and dosage levels. Now, the first time that medicine is used on patients is in the so-called phase 2 trial, where a small number of patients, maybe 100 or 300 patients, are employed or used to test the medicine with, of course, proper controls and consent forms and all that. And that looks at the effectivity and the toxicity of the medication concerned. Once it is established that the medicine is effective and not very toxic in a phase 2 trial, it is then put on to the larger phase 3 trial, where it is used on a large number of patients, maybe from 1,000 to 3,000 patients, and it is then evaluated for effectivity and long-term safety. And only after a successful completion of phase 3 trials is the drug released for use in the patient population, in the normal population. And that is the process of the FDA approval. And after the release in the market, there is what's called a phase 4 trial, which looks at post-marketing effects, long-term safety, and looks at the cost implications of a given drug. Now, we have to know when we are reading an original article what phase of the trial it is, and only if it is phase 3 and above should we completely accept the outcomes seen there. Now, if one puts a drug through these processes, it will give you an idea of what it takes to develop a drug. On the left-hand side here is the duration. A preclinical phase will be about 3.5 years. Phase 1 will take a year, phase 2, 2 years, phase 3, 3 years. So by the time you get an approval for a drug from the day it is, the experimental work has started, it will be nearly 9 to 10 years. And if you start with 5,000 compounds, perhaps you will have only one that reaches the clinical practice. This is one of the reasons medicines are very costly, because the whole process of developing these drugs is an expensive and a tedious process. Now, if you are applying the results of a study, as I mentioned earlier, you have to make sure that the results are from a completed phase 3 study. If you have phase 1 or phase 2 studies, you cannot use it in common clinical practice. Evaluating the end points is extremely important. I give a standard example of a patient where a cancer drug is used, anti-cancer drug is used. Now, if the patient has a metastasis which is 10 centimeters in diameter in the liver and lives 6 months with it, without the treatment, and with treatment, he shows a reduction in the size of the tumor by 5 centimeters down to 5 centimeters, but still lives only 6 months, then what is the point in using the drug? You have not increased the longevity. If you want to use a particular drug, the end point must be clearly understood. There must be an improvement in quality of life or a substantial increase in longevity. Only then should you be using such a drug. You must evaluate for adverse reactions. Most medications, whether you like it or not, have adverse reactions, and those adverse reactions must be minimal before you can exhibit it to your patient. And again, many newer drugs, particularly in the field of cardiology and oncology, are very expensive, and one has to look at the costs involved to the patient before we use the information and exhibit those drugs on our patients. Now, having said all this, we have now understood the phases of a clinical trial, the use or the role of the primary literature and of the secondary literature. We have also looked at the kinds of studies that we know: retrospective, prospective, controlled trials, and blinded trials. Now, when you put all this information together, you come to the level of understanding or deciphering what levels of evidence is. Now, generally we recognize 5 levels of evidence. The highest level of evidence, level 1 evidence, is seen from randomized controlled trials. As I said, they are the best evidence that you can have. The second level is from large prospective studies called cohort studies. The third level of evidence is case-controlled studies, where it's not a large cohort, but nevertheless a kind of good number of patients, perhaps 200, perhaps 300 patients, on whom you have a good study, good prospective study. The fourth level of evidence is what are called case series, where you may have 10 or 15 or 20 cases. While we cannot accept it as great evidence, there are many clinical situations where you don't get many cases. In those situations, for example, if you want an intervention on pheochromocytoma, which is not very common, or if you want intervention in rare syndromes, for example, you may see one or two of them in your whole lifetime. So when you have such kind of situations, while the level of evidence is not good, it is low at level 4, but that's all the evidence we have. And so it is not uncommon to use even level 4 evidence when you have rare cases. Level 5 and the lowest evidence is the expert opinion. While many experts may not like to see this happen, the fact of life is that an expert opinion not backed by data would not be acceptable in evidence-based practice. Now, how do you get this evidence? There is so much literature out there that to get an answer to a given clinical problem, you need to go through certain structured steps. And this is what you and I as practitioners always have to do. There is a method for each one of these steps, and this introduction does not permit me to give you the details of these methods. But I'll touch upon what these 5 steps are and then leave it to you to perhaps learn more about what the details of these steps are elsewhere. The most important thing is to ask the right clinical question. There can be many such questions. What is the evidence of weight loss on reduction in hypertension? That's number 1. It may be which kind of mesh has the best outcome rates in terms of recurrence. Such clinical questions have to be very incisive, and I'll tell you more about it in the next slide, have to be very clear, and once you have a question which is very clear, then you have to search the literature. Today, searching literature has become very easy with access to many databases on the internet, and there are many libraries where digital material is available, and you have to search the literature. And once you get the literature, based on the value of the studies that I mentioned earlier, you have to critically appraise the literature. In other words, you have to analyze how useful that particular information from that literature is. And once you're convinced that that piece of information that you get from the literature is useful, then you have to apply that literature to your patient. Apply that point or that information to your patient. And that doesn't stop there, because at the end of the day, the outcome is what we are all looking for. Then you have to evaluate the patient, keep him under follow-up, look at the correct end points, and evaluate the patient before you accept that that particular literature, what it propounded or what it said, was indeed correct. Now, asking the clinical question, the most important part of getting the information in the so-called 5-step procedure that I mentioned earlier is to ask a proper clinical question. The clinical question can best be described by the acronym called PICO, P-I-C-O, where P stands for the patient. Let me give you an example in this process. Suppose I have a patient with a hernia, an inguinal hernia, who needs a repair, and my issue is, in that particular patient, which is the best kind of mesh that I should use for best outcomes. Now, the first thing is, I look at my patient. He is a 75-year-old, a diabetic and a hypertensive, with perhaps some prostatism, perhaps some IHD. Now, I need to look at a series of papers which includes a similar population. That is the P part of it. I really cannot look at a paper that gives me information on a young patient who is an athlete and who is very fit, and then use that information for operation on this patient. So I must first look for patients who are similar, or studies where patients similar to my patient are studied. The next one is intervention. Now, many types of meshes can be used. I would like to know whether a polypropylene mesh is better, whether I should use some other mesh like PTFE, or whether I should use a dual mesh or whatever else that is required. That is the intervention. And so I must select out those papers which have these interventions in place. And then I must go to the C part of it, which is comparison. We need to have papers where each kind of a mesh in a given population is compared with another kind of a mesh. And then you see what the outcome is. And once that is done, I now have to decide that it is really the outcome that I want to study. The outcomes may be different in different papers. My primary interest is recurrence rates. Secondary outcome may be infection rates. It may not include chronic groin pain, for example. So you also evaluate which is the best or the most important outcome that you're looking at, and then look for such papers. Once you frame this question, in summary, I'm going to say again, I'm looking at a set of articles where the intervention of different kinds of mesh are compared in an 80-year-old patient with comorbidities, and the outcomes that I'm interested in are recurrence and infection. Now, once I have this clear-cut question under my belt, I then do the search of the literature and get the required data and get the required evidence. Now, all this may look very complicated when you listen to it in a formal lecture like this, but in fact, these are very simple, and once you go through 5 or 10 such questions, then automatically you will get the idea of forming the questions in an incisive and a clear manner, and literature search becomes very easy. Once you have done the literature search, once you have read through the literature, you then get into the final phase of application of evidence-based medicine or evidence-based practice. The simple question you ask are the results valid? Now, to answer that properly, I'm reiterating what I have said as a summary. The first thing you must know is, was it a randomized controlled trial? Were there any dropouts? Were people who were supposed to be evaluated really evaluated? Was there an adequate follow-up? For example, in a case of a hernia, unless you follow them up for 2 years, you never know whether the follow-up was adequate or not. So a study which tells you recurrence rates at 6 months would not be valid. Was the intention to treat violated? There are different groups in the comparison of studies, and patients should not be shifted from one group to another, whatever happens. That is the intention or the philosophy of intention to treat basis. Now, this should not be violated, and you need to look for whether it was violated in a given study or not. Were the investigators blinded? I have told you enough about it. Were the patient groups similar? Now, these are the kinds of questions that you need to have, and the final question is, treatments other than intervention, were they equal? That means whether the confounding factors were accounted for or not. So once you look at all these factors, then you know that that particular paper has real value. And once you know that you have valuable information, that's not the end of the line. Now, is it really relevant? What was the treatment effect? I told you about the reduction in the size of a tumor. It is of no significance if you just get reduction in the size. You need the patient to have better quality, as I mentioned earlier, and to live longer. Was that really there or not? How precise was this measurement? Now, if you find an X-ray measuring something, it may not be adequate. You may need a full CT scan to measure something. So were the proper interventions applied? And finally, we have to ask our questions. When all these are conducive, when you have found out that the results of that particular search and the evidence means that a particular intervention is good, let us say, as an example, the polypropylene mesh is good for hernia repair. The final question I ask myself as a clinician, is this result applicable to my patients? Now, how do I do that? Are my patients similar to the study group? This would be necessarily so because your PICO question would have addressed this. Was the outcome relevant? I have mentioned this before, but here is what is important. Are my skills similar? As a surgeon, am I trained to use a polypropylene mesh or not? Now, if you're not, it is my responsibility before I start doing it to get myself trained before I do that. So are my skills or is the infrastructure that we have, is it adequate or not? That is the kind of application of thought you must do before you actually practice evidence-based medicine. In short, ladies and gentlemen, The whole concept of EBM, I hope I have put across in this presentation. The philosophy goes like this. If medicine is to be a science or a learned profession, if it has to get above, to put it very bluntly, quackery, we need to think critically about how and why we make those decisions. Being scientific is about asking these questions of how and why and getting scientific answers. I have made an endeavor to tell you what science is and how answers become scientific compared to anecdotal experiences. But again, you must go back to Sackett, the father of evidence-based medicine, and listen to his good advice. He says this: good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. This is an extremely important statement. As doctors, we have a lot of experience with a lot of diseases, but those anecdotal experiences are not very good, but they are not useless. We have to understand that we have to go for scientific evidence as gleaned from the literature, but that cannot be blindly applied to every single patient. There are so many factors other than science that come into play. It may be social factors, where he lives, economic factors, what he can afford, what he cannot afford. All these factors come from experience alone and not necessarily from a scientific literature, from a journal. You have to put all these factors together and do what is best for the patient. Ladies and gentlemen, I hope that this presentation was useful to you. As we can see, if we have to climb the ladder and get proficiency in our respective careers, we really have to practice evidence-based medicine. This presentation has been an introduction to make you familiar with the basic concepts of this phenomenon called evidence-based medicine. The KMC is going to give you approved credit hours and points that will help you to accumulate your required credit hour points if you answer correctly some of the objective type of questions that we're going to present to you on the web. Thank you very much for your patient listening.